Vulvodynia is a condition that causes severe pain in the vulva. It can make some activities feel unbearable, such as sitting for long periods of time or sex. Today, Dr. Christine Vaccaro and Dr. Anita Mikkilineni will help us understand the symptoms of vulvodynia and how women can start their path to healing from their pain.
Welcome to Sex Care Self-Care, a conversation on women's sexual health brought to you by the Patty Brisbane Foundation for Women's Sexual Health. I'm your host, Patty Brisbane. Today we are discussing vulvodynia and its impact on women's sexual health. I am joined by two of our medical advisory board members, Dr. Christina Vaccaro and Dr. Anita Mikkilineni. Dr. Vaccaro, could you please introduce yourself to our listeners and let them know what you do on a daily basis?
Of course, Patty. Hello, I'm Dr. Christine Vaccaro, a proud member of the PBF Medical Advisory Board. I'm a fellowship director for urogynecology and an associate professor of OBGYN in Bethesda. And on a daily basis, I take care of women's pelvic floor conditions, urinary incontinence, bowel leakage, pelvic organ prolapse, and sexual complaints. Happy to be here.
I'm so glad you're here. Dr. Mikkilineni, could you tell our listeners who you are and where they can find you and what you do on a daily basis?
Hi, yes. So I'm Anita Mikkilineni. I'm a board certified full scope OBGYN at an academic institution in Washington, D.C. And I'm also a sexual health and pelvic pain specialist and educator. I'm faculty at our Sexual Health and Gender Affirmation Center, known as our SAGA Center, and the proud rotation director of our sexual health rotation for all of our OBGYN residents. And I'm also very excited to be here.
Okay, Dr. Mickey, what is vulvodynia and what are some of the symptoms?
This is such an important question. In medical terminology, anything that ends with the word dynia usually mean that organ is experiencing pain. So really that term is a symptom, pain in the vulva, not a diagnosis. So symptoms can really vary depending on the underlying cause. Vulvodynia has a really broad classification, but traditionally it's vulvar pain of at least 3 months duration without a clear identifiable cause or disorder. It can be further broken down into localized, for example, to the vestibule or to the clitoris, general, provoked, with a tampon, a speculum, intercourse. Is it new? Do they always have it? There's a lot of nuance to this definition, but that's the general gist.
So when you're talking about pain, is it burning? Is it throbbing? What kind of pain are we talking?
So we are pretty liberal with the definition of the word pain. Some women describe it as knives. Some describe it as burning. Some as persistent itching. Some people only experience it while they're having sex. And it's also important to acknowledge that different cultures and different ethnicities may define certain symptoms differently and not use the same terminology. So as clinicians, it's our jobs to kind of be detectives and figure out if people are presenting symptoms such as itching and burning and not straight going to yeast infection and thinking about other causes.
That's great. Dr. Vaccaro, how long does it typically last?
This is a great question, Patty. And this is so hard when I'm counseling patients because I always like to think of the glass half full, but in here we just really don't know. Like I wish I could say, oh, it's just going to be a few months and it'll be gone. But unfortunately, a lot of women experience this for months to years and sometimes lifelong. So the good news is, of course, we have treatments, but the symptoms can persist a very long time. And what I like to just say is it's a persistent condition that needs usually ongoing treatment. We'll get into the treatments later, and some I do think have a really high success rate. But I also want to add on to Dr. Mikkilineni's comments. This condition, pain, irritation, itching, burning. The interesting thing is it has to be an absence of some other identifiable cause. So when we do our inspection of the vulva, there has to be like no infection, no other skin condition. It can't be just a symptom of menopause, meaning it started with the menopause transition. Not to say that vulvodynia can't exist as well, but it has to be an absence of some other identifiable condition.
Dr. Mickey, if a woman thinks that she might have vulvodynia, if she's listening and she's saying, I have some of these symptoms, how would she go about getting diagnosed?
So a woman is diagnosed if she meets the criteria that I mentioned before, and we've ruled out other etiologies, just like Dr. Vaccaro mentioned, infectious, dermatologic, cancer, trauma, just to name a few, menopause. And when women have pain, we want to know where along the course of that nerve it's coming from. So there's a lot of variation here by provider. Once vulvodynia is concerning. And in our clinic, for example, we start with a really thorough history first, because that's probably the most important thing for us to figure out where someone's pain is coming from. And then for our physical exam, we typically start with a Q-tip test, testing the most peripheral part, your nerve endings. And we do this while the patient watches, so they can also verify where their pain is and understand their own anatomy. And we'll kind of stepwise work by anesthetizing. We'll, start topically and retesting it to see if that takes the pain away. And we work our way backwards to figure out, is this at the tissue level? Is it at the nerve level? Is this at the spine? And we work our way systematically backwards to figure out where the pathology is. Again, a lot of variation here in providers, but that's typically how we approach it.
Love that. Dr. Vaccaro, is there a cure for vulvodynia? And are there any treatments that are available for this?
Yeah, so unfortunately, there's no specific absolute cure, but I do think vestibulectomy comes close, but this is only indicated for certain patients that have localized provoked symptoms. So there's several treatments, though, that we'll get into. But again, it does differ based on the particular kind. But just in general, for all cases of vulvodynia, there's a lot of self-care treatments that are available. I always recommend that women, when they're washing themselves, wash gently, only use water on the vulva. I think a lot of women, can overdo soaps and bubble baths and other chemicals, and that can be really irritating to the sensitive tissue. So I really try to emphasize that a lot, water only to the vulva. And then some women also need just another layer of protection. So Aquaphor, some other preservative-free petroleum-based ointment can really be helpful, just to help that, their clothing doesn't continue to rub on the skin. It just provides a little layer of protection. I also like recommending sitz baths, which especially after sex. And the sitz bath is basically just a lukewarm water, either in a sitz basin, which sits in the toilet, or they can use their bathtub. And I add in unscented Epsom salt and just soak the vulva in that 1 to 3 times a day for up to 15 minutes. And that really helps just kind of draw out the inflammation and discomfort, and helps with like itching and burning as well. Other things, avoiding any harsh chemicals in their laundry, detergents. If they're wearing any sanitary pads that have a lot of harsh chemicals, I always recommend 100% cotton for any sanitary pads. And then also, trying to limit a lot of pressure on the vulva. So other things that can cause a lot of pressure, like bicycle riding, horseback riding, things that there's just a lot of pressure right on the vulva, trying to limit those activities. And most women kind of already have figured that out and are already limiting those activities. With sexual activity, if that's even possible, because some women, that's kind of why they're coming to me, is because now they have so much pain that's influencing their relationship. A lot of women come in saying, I'm on the brink of divorce, etc. So a lot of women, this is the reason they come in, is because sexual activity is impossible. However, if we catch it early, or they have less severe symptoms, just using a lot of copious lubrication, again, to avoid friction to the vulva. Sometimes, with a lot of reapplication. I always recommend to avoid any warming or cooling lubricants, because sometimes, the loving, partner wants to get things all spicy and sees this product that looks really exciting. And I've had women with this condition just be in aggravating pain for days to weeks after some sort of heightener or warming or cooling lubricant. So just plain lubricants. And then just remember, this is a team approach to this condition. So getting your pelvic floor physical therapist involved to help relax the pelvic floor muscles. A lot of times, again, these muscles have been in such a contracted state. They've been like guarded for so long that it's just hard to relax. Even after we treat and improve the pain of the vestibule or the vulva, the muscles sometimes can be just so tight still. I kind of make the analogy, like if you injure your neck, your muscles around your neck start contracting, and we have to then relax the muscles around the neck, and those muscles can actually have pain in them too, just from being contracted for so long. So a good pelvic floor physical therapist here is critical. And then couples therapy, usually the woman will go on her own first and then bring the partner in once the therapist and her are comfortable. Again, great sexual therapists are available on the AASECT, AASECT.org website, so that the partner understands that there's a pain situation. Again, I often use the analogy of the hot stove. If a woman puts her hand on a hot stove, you don't want to put your hand on the hot stove again, like you learn your lesson once. And it's, sometimes it's good for the partner to hear that as well. It's not that they don't want to engage, it's just it's really painful. There's also like other adjunct therapies like acupuncture and nerve blocks and Botox that have also been looked at. Specifically for the type of vulvodynia that I think can be actually well treated, which is this, what we call localized provoked, meaning it's localized to a specific special tissue that's just inside the little lips of the labia and before the vagina. It's this little strip of tissue called the vulvar vestibule. In this area, we can use local numbing medications. There's certain antidepressants and nerve modulators. Common ones that we use are Cymbalta, Elavil, and Neurontin that decrease pain. And then we can also remove that piece of tissue, and that's called a vestibulectomy. There's lots of videos you can find online about that if that's something that is interesting to look at. But the nice thing about a vestibulectomy, again, for only for provoked pain, meaning if you're sitting and you're always having pain, this is not an option. But if it's just with touching, meaning tampon insertions, penetration, vestibulectomy is actually very highly successful. Some of the studies show upwards of 90%, because you're actually removing the tissue that's causing pain. And this tissue is very specific embryologically. It's a very specific tissue, and removing it has a very high success rate. I do want to talk really briefly about a condition called neuroproliferative vestibulodynia, and this is a condition that is associated with umbilical hypersensitivity. So the belly button actually hurts as well, which is kind of a telltale sign if a woman comes in and we're doing the exam and you also examine the belly button, it's also extremely painful. And this can be something that's acquired, but most often it's congenital, meaning they're born with just really hyperactive nerves, and the belly button and the vestibule actually have a common link as far as embryology goes. So it's a kind of a very telltale sign of this condition, and this condition can also be treated well with vestibulectomy. And lastly, I promise I'm almost done here. There's hormone-mediated vulvodynia. Okay, this usually is associated with long-term oral birth control pills specifically, and this causes a reduction in testosterone on the vulva, and it's a kind of a complex mechanism how this works. But having that reduction in testosterone, this very testosterone sensitive area, can cause pain. What we have to do then is to actually apply an estrogen testosterone cream. Some studies show there's another product, intravaginal DHEA, that's also been shown to help. And again, this is a hormone issue, and we have to then address it with hormones. Whew, that was a lot.
That was a lot, but that was so good. Thank you.
Anita, okay. Do you have anything to add?
No, I think you covered it all.
Okay, so here's my trick question. All right, you absolutely killed it by talking about everything that can happen, and even going to a physical therapist. But Dr. Mickey, how common is it? How common is vulvodynia? And let's just say that she goes into her general practitioner or her maybe gynecologist, and she's presenting with some of this pain. Would they know where to start, where to go? And if they don't, can you talk about that? Because I want all the listeners out there not to feel afraid to talk. And if they don't get the right answer, what should they do?
Yeah, thank you for bringing up this really important topic. The truth is, it's probably incredibly underreported, and we don't actually know the number. Some studies have shown that the prevalence is up to 16% of women coming in have some degree of vulvodynia. And again, that's a very broad term that encompasses all different forms of pain. And another study showed that only 7% of patients even initiate a discussion about it. There's another study that showed 90% of people discussed it and their PCP or their GYN didn't even know how to address it. So what the reason I think it's important to talk about how common is vulvodynia is because we need to study it more. We need more epidemiological data, and we need to create a culture in which women are not fearful of asking these questions and talking about their pain, and get rid of this culture of normalizing discomfort and pain throughout a woman's lifetime. So I'm sorry I don't have a perfect answer for you. I think somewhere between 8 and 16% is what the data tells us right now, but we need more research and we need women to feel empowered to be advocates in their own health. In terms of if it's well known in the medical community, this is another really passionate thing for me personally, because as an OBGYN, you know, and also as a woman, I was shocked at how little training, if any, we received in my program, which was a very good program. And I realized that that was just how it was across the board in OBGYN. As the women's health providers, we didn't get that training. And it's not the fault of an individual provider. Most of the time, you know, your doctor is there trying so hard to help you. And when they come up empty, it isn't because they don't care about you. It's because they truly don't know or didn't receive the training. And, you know, I'm hoping that as a society, we come together and identify these deficits and are able to educate not just the new generation of learners, which is something I'm very passionate about, but also people who've been out there practicing for 10, 20, 30 years about this field, so that women don't feel gaslit when they come in and complain about something. They know their bodies and they've lived it with them their whole lives, and a medical provider is meeting them for the first time and telling them that it's in their head is not acceptable. So, you know, there's this whole conversation of who owns the vulva. Is it the OBGYNs? Is it the urologists because they're sex specialists? Is it the prime? Like, everyone keeps throwing it around because nobody feels comfortable. And ideally, we should get to a place where anyone who deals with women's health issues or sexual function feels at least comfortable to diagnose and treat and triage these patients. So that's my long answer to your question.
Is it because it's not being taught, it really studied? Is it because of the lack of research in that area?
It's all of those things. And I do really feel like it's important to acknowledge the history of a field when you're looking at how medicine is practiced today. And there's some really good literature out there. Specifically, a colleague of mine at Yale put out a paper about the history of vulvodynia that I think is really important that any provider read, because it kind of goes through every step over the last couple hundred years of the misogynistic foundation of obstetrics and gynecology and why we are where we are today. And it's because historically, none of these concerns were taken seriously or even acknowledged as real. That's evident by the fact that all of our diagnoses codes for pain and sexual function are mental health codes. We can't even get reimbursement for them outside of the mental health field. So, you know, if you look back in history, you see where all of this started. And not only do we need to educate ourselves moving forward, but we have to acknowledge our historical origin of our fields in order to inform better patient care.
And Patty, if I can add on to that,
Yes.
I mean, Dr. Mikkilineni mentioned gaslighting, and I think this is something that we're as a medical community doing really poorly, is telling women, again, it's all in their head. So the problem with vulvodynia is when you examine a woman, the tissue looks 100% normal. Like, it looks beautiful. Like, there's nothing visibly wrong. So to an untrained provider, which again, we've established there's not great training for examining the vulva and knowing about this condition. They say you're fine. There's nothing here. You know, it must be all in your head. And again, sometimes they leave with antidepressants, et cetera. And the woman leaves feeling just completely defeated. So how common is this? If I see a young patient that's having pain upon penetration or pain with insertion of a tampon, in my mind, it's gonna be vulvodynia, like in my mind, number one. So with those symptoms, that's the most common diagnosis. And it's really, of course, I see a lot of patients like this, not uncommon at all.
All right. Well, is there something that causes vulvodynia, and are there any risk factors?
Yeah, so I mentioned congenital. So sometimes patients are just born with this hypersensitivity of the belly button and the vestibule, that small amount of tissue right at the opening of the vagina. And again, they have pain with first attempt at intercourse. They have pain with first attempt at putting a tampon in. So that is, again, a very classic presentation. And then there's acquired, which is not congenital. It's just something develops over time. And I would say this is the majority of patients that I see. We're not sure why it happens. We're not sure the etiology. Was it, some sort of infection that then triggered the nerves to be inflamed? Was it another organ system that was really painful, like the bladder? We've talked before about bladder pain syndrome that then caused the nerves to sprout and grow and then cause pain in another location. We're just not really sure. Is the immune system attacking itself? We're just not really sure why patients get this, except for a very, very high risky thing, which is birth control pills. So I think, I would say most reproductive age women in their lifetime are offered birth control pills, and thank goodness it doesn't happen to all of them. But this is a very highly prevalent condition, meaning if they have a long history of birth control pills, they're potentially going to have that hormone-mediated vulvodynia that I'm talking about because of the hormone interaction. I actually remember an ISWISH, which is International Society of Study Women's Sexual Health meeting over 10 years ago that had a nice debate if there should be a black box warning on birth control pills, not only for potentially the link to vulvodynia, but also the link to low libido. In my practice, I don't prescribe oral birth control pills because there's so many other great options that don't cause these, negative complications. Like I mentioned, also, there's other pain syndromes that can be linked to this, meaning if you have another pain syndrome in the pelvis, to me, that's a risk factor. So other pain conditions of the pelvis include bladder pain, endometriosis, pelvic floor muscle pain. So these conditions, again, just because of their proximity, are usually, highly prevalent, associated with each other. And then other just total body diagnosis that also are sometimes linked, like anxiety, depression, history of trauma like PTSD, sexual trauma, fibromyalgia, even patients that have like really bad TMJ just because of the anxiety kind of is associated, and then or tension in the jaw, and then also irritable bowel syndrome. So these are kind of like, conditions. When I see a bunch of these on their medical history, it also makes me think a little bit more of vulvodynia.
Wow.
I was just going to add two things there. I feel like birth control pills in that context can be really bad, but for some women, it's the only contraception that they'll use. And it has a lot of other benefits, with premenstrual dysphoric, terrible PMS, migraines. There's a lot of great benefits depending on what formulation you are on birth control pill. And there's data showing it's not everyone on birth control pills who's going to get this. It's people with a very specific receptor subtype, we believe, and data is starting to bear out, that are just more sensitive to that lower testosterone levels circulating through their body. And they just need a more robust level of testosterone to have healthy tissue down there, and other women don't. So I don't want women to stop taking their birth control pills. If it's the birth control that works for you, absolutely keep taking it. And if you don't have a problem, you don't have to worry about it. And the other thing I wanted to mention with the acquired neuroproliferative is with recurrent yeast infections being one of the suggested mechanisms for high levels of inflammation causing more nerve ending growth. A lot of women will come in or getting the incorrect workup for yeast infections, where honestly, some doctors are not even doing swabs or checking under the microscope and just throwing medications at patients without doing their due diligence with testings. And I feel like you might not know if you have a drug resistant strain, and it can lead to you dealing with yeast infections for longer and longer and longer, if that even is what's going on, and causing more inflammation. And setting off the problem. So making sure that, you're getting the right diagnoses as well and the right treatments.
So I'm going to throw a question in there that wasn't on our papers. So is it best so you're going to go to the doctor, you're looking for birth control. Is it best to maybe have, if you have blood workup done or, your levels checked, would you know more about whether your body's going to take on the birth control easier, or do you know
So
what I'm saying?
right now,
You're going to have future problems down the road. Yeah.
Right now, getting blood work is not recommended to be a part of making the initial diagnosis. It's really a diagnosis based off of someone's history and their physical exam. When we're getting blood work on these patients, suppose we're diagnosing hormonally mediated vulvodynia and we want to start them on a gel, I'm mostly getting those levels to make sure that as we treat moving forward, you're not absorbing too much medication and not going to a higher level than I think is safe for you. Sometimes it can help support the diagnosis, but it's not diagnostic criteria by any means. Your hormones levels fluctuate so much throughout your cycle that you want to make sure that when you are getting a lab, you know what you're going to do with it and how you're going to counsel that patient about it. And I don't think that the data is there yet. Maybe it will be in the future to be able to get someone's hormones levels and look at that data point itself and make a diagnosis. In most cases, when we're talking about vulvodynia, at least.
Okay.
And Patty, if you were asking, is there a test that we can do before putting a woman on birth control pills to see if she's going to be one that has a particular risk for vulvodynia? That test, to my knowledge, does not exist. If that was a part of your question. Again, in my practice, I number one, sorry, now we're challenging birth control pills here. Obviously, reproductive capacity and the rate to control your reproductive capacity is super important. Just we have so many formulations, and we know the birth control pill also has, sometimes a little bit higher risk of failure just because it has to be taken every day.
Mm-hmm.
We know that long-acting reversible contraception has the highest rate of pregnancy prevention and also isn't associated with these other potential complications. So when I'm counseling a woman who is coming in for a request for birth control, and I'm seeing her usually for some other reason as well, I try to start with the long-acting reversible contraceptives like an IUD or an implant in the arm. And then if that's not something they want to do, then usually like an intravaginal ring or a patch, so that they're not, again, exposed to these potential risks. But again, sometimes you do have to use a pill.
Okay. I just thought it was worth asking. So, Dr. Mikkilineni, how might vulvodynia affect a woman, her life and her relationship with her significant other? And what can she do to help offset these symptoms?
So this is a pretty big question, understandably. And, it goes just beyond, putting something in the vagina and having pain there. My patients have told me how they have just acclimated their life to their vulvodynia. And for example, if there's a pool party, they just know they're on their period, they're just not going to be able to go, or they're not going to get in the water because they can't fit a tampon in. Or they just put on routine cervical cancer screening with a pap smear because they're scared. It's like PTSD going to the doctor's office. Like, these are really important life events, health screening events that sometimes just don't happen for our patients, and they just accept the consequences of that. And of course, that has a huge effect on their life and their ability to have relationships. I had one patient who ultimately decided to get a vestibulectomy, was my partner, because she was with a guy and he liked her a lot and basically said, "I'm sorry, I just can't be with you if we can't have penetrative sex." And she came to the office following that being like, "I'm ready for the surgery." And it just has devastating consequences. And it's magnified by the fact that they, also, again, get gaslit by the medical community when they're dealing with all of this trauma in their daily life. And then they're also told nothing is wrong. So, their mental health is just a mess from all of that. And offsetting the symptoms really kind of depends on the etiology. There's some, simple remedies that Dr. Vaccaro already went through that can help with symptom relief and also preventing further irritation or exacerbation. But really, you want to figure out what the etiology is so you can get the correct counseling for what the best treatment is, because we don't want to just be numbing the area every time you want to touch that tissue. We should be figuring out what's wrong and giving you a better long-term solution. And again, this is done through shared decision-making and making sure that you're tailoring a care plan that's specific to both your diagnosis and what the patient's goal is. Like maybe you want to be able to do a pap smear. Maybe she just wants to, be able to wipe without burning when she goes to the bathroom. So really meeting your patient where you're at is probably the most important thing.
There you go. Dr. Vaccaro, what resources are out there for women who is suffering with vulvodynia? Where can she go?
What's that?
Where can she go?
Yes, where can she go? There's actually lots of great resources, and I'll go through them one by one. The first that I like is the National Vulvodynia Association, and that's nva.org. I think we can probably include these in the notes, all these links. But this website has a lot of all those self-help treatments. They have a nice handout about self-help. They have support groups. So it's really nice then to connect with other women. Other women love to connect, and they love to share their stories, and they love to also, through education of each other, help each other. So the support groups are really wonderful. So it's a great source of education. The next is the International Society for the Study of Vulvovaginal Diseases, and this is isvvd.org. And again, they have lovely educational handouts about vulvodynia to explain each of the categories. Next is ISWISH, the International Society for the Study of Women's Sexual Health. Again, lots of education, lots of resources on that website. And then lastly, I would say American College of OBGYN also has information on vulvar pain. So those are kind of the in order, I would think, for me to look for resources. That's where I like to look and like to refer patients.
And this
can I add one?
Happen at any age, by the way?
Yes, any age.
Can I add another organization?
Of course.
There's a grassroots movement made by patients who suffer from chronic vulvovaginal and pelvic pain called Tight-Lipped. They also have a phenomenal podcast if you would like to listen to the episode about the misogynistic history of OBGYN, and they're huge allies in helping providers and trainees learn how to do this so they go out into the world and take care of women well. It's a great place to both be heard and have your story told as a patient, and also find a community of people who have likely been through exactly what you've been through as well. And they have chapter communities in every city, so you can meet them in person too.
I'm definitely going to tune in, and I'm sure many of our listeners will do the same. Is there anything else that you want to add for our listeners out there that they should know about vulvodynia that we might have missed today?
For me, it's what we don't know and how important it is that we get included in research initiatives moving forward with more federal government interest in women's sexual health. I know cardiovascular disease, diabetes is all really important, but they've got some funding, and we need more than just the Patty Brisbane Foundation spotlighting how important this issue is.
I agree 1000%. We can't be the only one, because quality of life is important to all of us. So I want to thank my guest today for this great conversation. And if you like what you heard today, please rate and subscribe to our podcast. For more information on the Patty Brisbane Foundation for Women's Sexual Health and our focus areas, visit pattybrisbanefoundation.org. Remember, sex care is self-care, and sexual health matters. Thank you.